I am going to introduce a very good friend of our research organisation here at University of Queensland, and that's Professor Jan de Waele, who's an intensive care physician from Gent University Hospital in Ghent in Belgium. And Jan is going to talk to us about the diagnosis of sepsis in a patient colonised with multi-drug resistant organisms. Jan, can I hand over to you? Thank you.
Thank you very much, Jason, for this introduction. And while I'm sharing my screen, of course, first of all, I want to say good morning, good afternoon, good evening, wherever you are. Diagnosis of sepsis per se, I think already is quite a challenging topic. And if you add a bit of flavor, add a bit of MDR flavor to this, it becomes even more complex. But I'll be more than happy to share my thoughts on how this is complex and how actually the presence or the fear of multi-drug resistance affects the whole decision making. So these are my disclosures that come in a minute, right? These are my disclosures. None of them, in fact, really relevant for this particular presentation. Now, before starting off with MDR, I do want to give you a brief update on where we are in terms of COVID, what has been determining our lives for the past 18 months. A few days ago, actually, the outdoor terraces in Belgium were opened again, and this is a picture I took on the very first morning at 8 a.m. where everybody already was heading out to the cafes to have a beer. So things are looking good. Things continue to improve here, not so much because people are clinging on to the restrictions there were, but most of this comes because of the vaccination campaign. I'm really very excited about this. Vaccination take-up has been really high, up to 97% in the 60 plus population. So that's really looking very good. And in the next few weeks, all of our 18 plus population will have been offered at least one vaccine shot. So things hopefully will be continue to improve. Of course, I'm not talking about COVID today, although the challenge that I'm talking about is actually something that also applies to a large extent to COVID-19 patients. But of course, as you're in Australia, as many of the audience in the audience today are from Australia, are probably unfamiliar what COVID-19 effect really is. Let's just stick to the multi-drug resistant infections. So I would like to start just with a case story, just to make you understand where this problem lies. Imagine you're treating this patient, a 45-year-old male who's been in the hospital for weeks, admitted with acute pancreatitis, has had surgery, has been in the ICU for some time, most of the time actually, but was discharged just a week prior to this episode again, admitted with respiratory insufficiency. He gets some high flow nasal cannula, gets better. This is the chest x-ray. And of course, this could be anything. Clinically, has some fever, some inflammation on the lab, not abnormal in a patient with pancreatitis. And the question is, what do you do? I mean, do you start antibiotics? This patient is not in overt sepsis or septic shock. And especially, how does any microbiological information change that? So if you would know indeed that cultures have grown something and are what we call positive cultures, does this really change? And that's a challenge I think we're often are confronted with. There's a number of things that go through our head in this situation when you decide what to do. Of course, this patient has multiple risk factors for multi-drug resistance. And of course, this is a vulnerable patient. There may be less tolerance for failure. The patient may deteriorate rapidly. This is probably more caused by the severity of illness and the comorbidities. But on the other hand, of course, you realize that MDR is a threat to your other patients, and you risk entering for this individual patient this vicious cycle of giving more antimicrobials, inducing more antimicrobial resistance. Now, do consider if you would know that in this patient, in previous culture, for instance, an MDR pseudomonas was found in the sputum, and an Enterococcus faecium was found in the fecal culture. So, for instance, how would that change your approach to the patient? Would that change your decision making? Would you start antimicrobial just because you have this additional information? Now, the way I see it, there are actually two diagnostic problems here. The one, of course, the first one is an important one. Does this patient really have sepsis? And the second one is multi-drug resistance an issue, or is this a risk for involvement of multi-drug resistant pathogens? And the big question also is, how is all the information we have helping us or not to make the right antimicrobial decision? So let's dwell just a little bit more on how to diagnose sepsis. This seems quite straightforward. Sepsis, as per the sepsis 3 definitions, it's life-threatening organ dysfunction caused by this dysregulated host response to infection. So two important items: organ dysfunction and infection. And we measure it. We use the SOFA score to quantify this, to help us. So this seems easy, but if you drill down, then actually there's two components to this. There's an infection that you need to diagnose, and there's the organ dysfunction that you need to measure. And whereas the sepsis 3 definitions give us good tools to describe and to quantify the organ dysfunction, sepsis 3 doesn't say anything about how to diagnose an infection. Actually, sepsis 3 explicitly says, well, this is not about diagnosing an infection. We focus on the organ dysfunction. So it's really a challenge to confirm or refute a diagnosis of infection in many patients. And because this is difficult, often we resort to starting antimicrobials empirically. And don't get me wrong, in a lot of situations, this is really important. If you have a patient presenting with what looks like septic shock to you, absolutely, you need to initiate antimicrobials. But in a lot of situations, probably the majority of patients that you may consider antibiotics in does not present with septic shock. So diagnosing sepsis, as in diagnosing organ dysfunction, is relatively easy because we know the scores, we know what organ dysfunction is, we know how to quantify it. For me, the big issue, the big difficulty lies in diagnosing infection in many situations. And I admit, when you have a patient with a peritonitis, for instance, then infection or absence thereof is pretty straightforward. But in a lot of situations, such as patients with respiratory insufficiency, it's much more difficult. And diagnosing infection is about, well, first of all, looking at signs and symptoms in the patient's clinical examination, and this is of paramount importance, of course. And also what I call a contextual approach, where you consider a number of infections that could be present. If a patient presents like 1 week after major abdominal surgery, esophagectomy, for instance, with inflammation, then the likelihood of a GI leakage is higher than in a patient who just comes from home and presents with respiratory insufficiency. The second question then is, are multi-drug resistant pathogens involved? And that's, again, that's often a tough one because we know more or less what risk factors are. And most of the time, actually, what they do reflect is the intensity of medical care that the patient received in the past weeks and months. So duration of hospital stay, exposure to antimicrobials, comorbidities, invasive devices. Well, basically, a lot of our patients in the ICU would tick multiple of these boxes. And for this, we have developed scores to evaluate multi-drug resistance probabilities, but often these are of limited value only, especially when you start using them in another environment, in another ICU, then the sensitivity, specificity of these scores are often much worse. So it may be easy to rule out infections in some of these situations, rule out multi-drug resistance in some situations, but ruling in is much more challenging. So it's not easy. And something, of course, we cannot forget is that these risk factors are not signs of infection. It's not because a patient has multiple catheters, a patient has had antimicrobials beforehand, that this is now an infection. So this is just a risk assessment and not necessarily a trigger to start antimicrobials. And that's why I often have this feeling that sometimes we just have too much information. I think it's a common problem. And I'm convinced that in our ICUs, a lot of problems are maybe even created because we have just too much information and we fail to recognize what is really important of relevant. And this, I feel, is particularly true when treating infections. So let's look at what I call the problem with cultures. When a culture comes back positive, that's when things start to get complicated. Very hard to ignore any culture. I mean, it could be if you do surveillance cultures, which we do, you get a lot of information each day on these patients. Very hard to ignore and very tempting to treat, especially in an ICU where you have very complex situations, where also if you're considering an infection diagnosis and you start antimicrobials, well, then at least there's one thing less to be worried about. And you can just move on and say, okay, we've got that covered. We've got that covered. The patient is on antimicrobials. But we should question for every culture that comes back, positive or negative, but especially positive, what is the real value of this culture? And compare it to yeast. When you find a yeast in a sputum culture, then it's pretty straightforward. We all agree that this is not relevant, but this may also be the case with other isolates, other pathogens, well, other microorganisms that are identified in these patients. It becomes even more pressing of an issue with surveillance culture. If you do surveillance culture, as I already mentioned, pathogens are not always causing infections, of course. There's tension between colonization and infection. But again, a lot of information that is difficult to ignore. And in some situation, this may have a paradoxical effect. And you may even have an increased antimicrobial use because you get all this information. Often when multi-drug resistant pathogens are involved, I mean, there's this even more acute feeling that you should do something. And in some situations, as we've seen, people are less eager to de-escalate because a positive surveillance culture at another site, not at the infection site, may prompt clinicians to continue the broad spectrum treatment. Although, again, the microorganism at the infection site is perfectly susceptible to much narrower spectrum antibiotics. So when you look at the reasons why antimicrobial use is so high in the ICU, and this is a nice figure that summarizes almost everything. It's about the patients and their severity of illness, the many catheters we are using, of course. There may be pressure of the pharmaceutical industry, but also, and this is a much bigger issue, I think, pressure from guidelines, specifically in pushing people to start antibiotics early. In some situations, a lack of knowledge, but also diagnostic uncertainty is so difficult to make to confirm a diagnosis, and also very important, this fear of missing this life-threatening infection. All of this leads to this heavy antibiotic use, but I think that also positive cultures, information overload should could and should be added to this table. So how can we solve this? Because I've listed a number of issues that you probably recognize, but I'll be discussing in the last 5 minutes of my presentation on how we may be able to improve this. A first and very easy, I think, or straightforward solution is involving a clinical microbiologist. I know many of you have antimicrobial stewardship teams working in your ICUs in your hospitals, but really closely involving a clinical microbiologist who not only knows about the local susceptibility, but who's also aware about these results and what they could mean. A clinical microbiologist will be very helpful to you in interpreting these results, and ultimately will reduce the number of unnecessary tests that will only confound your decision making. So I think that's a very easy and straightforward strategy. Now, may rapid diagnostics come to the rescue? And there's a lot of buzz, of course, around the PCR-based diagnostics, and we use them a lot, certainly now in this COVID-19 pandemic. Syndromic approaches for the respiratory tract, but also for all different sites. I'm not sure if this is really going to help. It may be even the opposite, because what is typical of these diagnostic tools is that it gives you a lot of extra information. You may identify a lot of microorganisms, but again, it's difficult to differentiate often between infection and colonization, and this needs further refinement. But this will happen as well. We do use it also a lot for very specific situations, but this is once actually you've decided that there is an infection and the culture is relevant, that you just want to know about, is it MRSA or is it a susceptible Staph aureus? Also for specific infections, bloodstream infections, of course, that's quite straightforward. If you identify a pathogen in a bloodstream culture, then obviously infection is present. But these more general approaches in respiratory tract samples is a little bit more complex. Improving biomarkers is another way, and I know the next speaker is going to talk more on biomarkers. I just want to mention how trying to identify infectious from non-infectious causes of systemic inflammation in a patient may be the next big thing. There's a number of tests becoming available that quantify a number of host genes. So this is more about the host response to the infection rather than the identification of microorganisms in the host. This is just one such example that gives you a score, which is in some selected population has been very helpful. You can see an AUC of 0.95, for instance, just here, which is, of course, a very good performance. One of the future things to consider is certainly data sciences and use of artificial intelligence, although there is a lot of use already of machine learning in the decision making. It's most often in the microbiology lab where it aids to detect multi-drug resistant pathogens. But also, I think in the future, this is something that we are working on here in Ghent, is trying to use all the data available, and this means clinical data, microbiological data, to improve the prediction of MDR involvement, MDR infection in ICU patients. So it's certainly one of the things to keep an eye on in the future. And what we can do in the meantime, I think, is just, well, work with the tools you have, and improving our diagnostic approach is critical. I do stress always the importance of clinical examination and contextual thinking. Both of them combined actually can help us to selectively image these patients and actually much improve our antimicrobial decision making here. And in the meantime, of course, let us also not forget that it is important to consider the urgency of antimicrobial therapy. Obviously, again, septic shock patients, they need antimicrobials immediately. But in many situations, the patients are not so acutely ill. There have been a lot of studies already looking at a watchful waiting strategy, where in the less severely ill patients with an unsure diagnosis, you don't walk away from the patient, but you just collect information, you reevaluate the patient after a few hours, and you may have found an alternative diagnosis, and there may be no need to start antimicrobials. So this strategy, I think, we will see much more of this in the future. So in summary, Chairman, ladies and gentlemen, I didn't solve the problem of the complexity of diagnosing sepsis in patients, but I do want to stress that the most difficult part is an infection diagnosis, because you need a suspected or proven infection, and I prefer proven, to confirm the sepsis diagnosis. This decision-making should not at all be affected by the mere presence of multi-drug resistant pathogen. And I understand why people may be worried about these pathogens, but the first thing is to diagnose an infection and not treat a positive culture. Be aware, and this is a very important one, that you may have in some situations just too much information, and try to focus on what is really important, and just keep in mind that a positive culture should not be a trigger for antimicrobial therapy at all. So for now, we'll have to do it with this clinical approach, with targeted imaging, and waiting a little bit from time to time. There are new exciting technologies on the horizon, and I think we will see a lot happening. But in the meantime, let's just stick to what we know and try to improve our antimicrobial use. Thank you very much, and I'll be happy to take any questions.
Thanks very much, Jan. That was a wonderful description of the challenges associated with when to start antibiotics in potential sepsis and the trigger that maybe the presence of an MDR organism may have on making someone want to pull the trigger, so to speak, a little bit earlier on. And, you know, it really is a big challenge that a lot of people wrestle with all the time. At the moment, there's no questions that have come through, but I am just going to take liberty of asking you one, which is slight extension of related to the topic, and that is, when an antibiotic is started, when do you think is an acceptable time to stop it? It's a bit of a leading question because, you know, sometimes the diagnosis of sepsis remains uncertain, but when do you think is an acceptable time to stop?
That's a very good point there, Jason. Now, first of all, we need to acknowledge that it's always much more easy to start an antibiotic than to stop it. And that's one of the frustrating things. And there's a lot of things that come into play here. Who started the antimicrobial? You know, if it's a senior, if it's the department chief who started the antibiotic, or maybe a junior resident, that may already be something where people are more reluctant or not to start or stop it. I think there's no specific moment in time where you can say that this is the right moment. I think there should be a daily critical evaluation of the antimicrobial. And a critical reevaluation of the infection diagnosis. Again, the organ dysfunction is always there. The patient may have something else. So don't look at any trends in organ dysfunction, but did we confirm the infection? And this should be a part of our daily routine, so to speak. Very important there also, I always try to emphasize that people should document the reason why the antimicrobial was started, and not only pulmonary, but really in detail. There was a little bit of respiratory deterioration and some sputum, and we were unsure. Also, maybe already giving some clues to those who make the decisions later on, because well, in many ICUs, there's a lot of people involved in this decision making, and it's really often hard to try to reconstruct what was happening at that moment when antimicrobials were started. So document the infection, document the rationale, any specific information that may help your colleague 1, 2, 3 days down the road to adjust antimicrobial therapy was started. It's, again, starting is much easier than stopping, and that's one of the big challenge I have.
Thanks very much, Jan. That's fantastic.